Thank you for joining today's webinar. Dr. Jim Bussel will now begin the program.
Good afternoon, everyone, and welcome to today's webinar on the management of maternal, fetal, and neonatal challenges. I'm Jim Bussel, Professor Emeritus of Pediatrics at Weill Cornell, and I am joined by my colleague and co-author, Ken Moise, who's a professor of women's health at the Dell Medical School at the University of Texas at Austin. Before beginning, we want to quickly share some information about the Foundation for Women and Girls with Blood Disorders and today's program. The Foundation's mission is to ensure that all women and girls with blood disorders are correctly diagnosed and managed at every life stage. With this, Foundation of Women and Girls Blood Disorders, affectionately known as FWGBD, aims to provide education to healthcare professionals on medical consequences and unique issues for women and girls with blood disorders. Since its inception, the foundation is focused on realizing its vision to educate providers and change lives through the objectives you can see displayed on the screen here. Next slide. As part of housekeeping, we're trying to ensure the best sound quality during the program, so attendees will be muted. However, you'll have an opportunity to participate in a Q&A with Ken and myself at the end of the program. You can submit your questions during or after the presentation portion via the chat box in your control panel on the right-hand side of your screen, and we will try to address them during the Q&A session at the end of the presentation. The next few slides detail our accreditation process. The activity is being supported in part by an educational grant from Janssen. And I should mention that both Ken and I work with Janssen, but you will hear independent, our best opinion views, data supported during the presentation. Continuing education credits will be provided, and a follow-up email will be sent to attendees explaining how to obtain 1 hour of CME for the program. The program has been approved for 1 hour of credit. The learning objectives are listed here, and we have disclosures coming up for both myself and for Dr. Moise right here, sorry. Giving you 10 seconds worth of benefit, okay? So all of the provider employees in control of contact have indicated about the disclosures, and we talked about you receiving an email after the program's conclusion with evaluation and the link for the CME. This is included in the handout and will be shared in the chat box at the end of the program. And now we're going to do our polls. The best way to clinically diagnose or identify most cases of FNAIT, fetal and neonatal alloimmune thrombocytopenia, in order to proceed with clinical management is select one of the following as the best ways to identify most of the cases. Include babies with intracranial hemorrhages both in utero and postpartum. Send testing diversity and await the results. Look at babies with bleeding beyond petechiae and ecchymoses after birth. like GI bleeds, intracranial hemorrhage, etc., or select babies with platelet counts less than 50,000. Please make your selection. Okay, so most people selected the right answer, which is that a low platelet count on day one of life seems to be the best way to include, let's call it 90+% of cases with FNAIT, and certainly include some others who don't have it. Bleeding beyond petechiae and ecchymoses isn't required. I don't know what just happened here. But if you select just ICH, you'll miss, say, 80–90% of the cases. We have the next poll. All of the following are serious complications of hemolytic disease of the fetus and newborn, except hydrops fetalis, neonatal sepsis, severe fetal anemia, or kernicterus. Please select one of the following that is not directly connected to HDFN. Okay, so most people selected neonatal sepsis. Kernicterus is a complication of hyperbilirubinemia and leads to potentially severe neurologic damage from bilirubin in the CNS. And I think the fact that some people may have selected this indicates how little we currently pay attention to HDFN, because it's been so well prevented by prophylaxis. Next poll, last poll question. All of the following are used as treatments of fetuses with hemolytic disease of the fetus and newborn, except in utero transfusion, intravenous gamma globulin, steroids, anti-FcRn, or exchange transfusion. Please select the one that is not at all routinely used as treatment of fetal HDFN. This is something of a shocker to me. Pending the use of anti-FcRn, which you're going to hear about extensively from Ken, who was the maven in this, in utero transfusion is the standard of care. IVIG is widely used, so it's interesting that it was selected as little. Steroids are the treatment that are not used, so that should have been the answer. And exchange transfusion has also been used, even rarely in utero. So we will look forward to hearing from Ken about this, and now we will proceed to talking about the program. And I believe that I am getting control of the slides here. So I'm going to tell you about FcRn, which is an underappreciated part of IgG use and efficacy. I'm going to talk briefly about the biology, and we're going to talk about blocking maternal to fetal IgG transmission, which will be what Ken will focus on in his talk. So we know that IgG alloantibodies can affect every organ system and are estimated to affect at least 2% of the population. The major mechanism of disease is these IgG alloantibodies recognizing antigens. Unlike autoantibodies, these alloantibodies can be more readily identified and their role in disease is clearer. And finally, as what I should be no surprise, IgG levels, plasma cells, and B cells are manipulable, as now is transport of IgG across cells. Oops, sorry. This slide is just to show you that inhibiting FcRn, excuse me, is widely used across a wide variety of diseases and is clearly entering the clinical space across many subspecialties. Here you see an IgG molecule that's sort of squished in the center with two FcRns, one on each side, binding to each of the Fc parts of the IgG to be able to transfer it. Here you see that FcRn is in the middle with the alpha helices and then with beta-2 microglobulin, the second part of it. Here you see an IgG Fc piece binding to it, and simultaneously on the other side, it can bind to albumin as well, which is why that's something that's often monitored with use of anti-FcRn. And here you see an FcRn monoclonal antibody binding to FcRn and blocking it from its effects. So what are those effects? Well, one of them is to recycle IgG and albumin. We'll be focused on IgG to protect it from catabolism. So what you see here is that when plasma is pinocytosed by endothelial cells and macrophages, IgG is included. These purple armchairs are FcRn, which bind IgG only in an acidic microenvironment in the acidified endosome. They then take it and transport it back to the cell surface, and the affinity changes so that the IgG no longer binds to FcRn and is recycled. An example of how this might be used is in myasthenia gravis, which is the poster child of anti-FcRn and has had at least 2 preparations licensed for it. You see here that we have 4 scales, if you will, and you're looking at the change in IgG, you're looking at the change in anti-acetylcholinesterase receptor antibody level, the one driving the disease, and 2 scales of quality of life. And you can see how when at the beginning here, an anti-FcRn is given, they all change together. The quality of life scales get better, the overall IgG and the IgG anti-acetylcholinesterase all go down together, and then as they recover, they all come up together. So this is an illustration, a best case scenario, if you will, of what happens with an anti-FcRn. Now, in pregnancy, we're interested in transcytosis, and you see here the fetus, and here's the mother's circulation and the fetus's circulation, and it appears clear that IgG transport is very dependent on FcRn. So from the mother side and the syncytial trophoblast, it clearly comes into the interstitial space. Whether and how much that's dependent on FcRn to get into the fetal circulation is not known. But in humans, IgG from the mother to the fetus to keep the newborn from being septic is primarily by this transplacental transfer. So we, and Ken is going to tell you about this especially, raise the question of, could we block transplacental IgG from the mother to the fetus and in that way make better fetal diseases caused by maternal IgG antibody. This is the article that Ken recently published in August of this year, and this is what he's going to tell you about. So Ken, over to you.
Yeah, thanks, Jim, and I appreciate your introduction. So I'll get control of the slides now. So a little bit of background first about HDFN, or hemolytic disease of the fetus and newborn. We know that when fetal cells that have antigens present that are incompatible with the pregnant patient enter her circulation, typically this is at delivery, dendritic cells then present those antigenic cells to the T cell, which then works with the B cell to make antibody secreting cells or plasma cells, and alloantibodies to those red cell antigens are created. Typically, this doesn't affect the first pregnancy because this is the sensitizing pregnancy. Again, typically the first child at the time of delivery is the one that's incompatible with the mother, and those cells can gain access at the time of delivery, although some can traffic earlier in pregnancy. But once that second child is on board, if that child has incompatible blood type also, these alloantibodies can cross the placenta, attach to the fetal red cells, and eventually cause fetal anemia. Now, in many cases, we can prevent this, particularly with anti-D formation, through a lot of events that can occur in pregnancy where, again, these cells can traffic. So we can give rhesus immune globulin. We typically do it at 28 weeks and then again after delivery to prevent this disease from occurring. But we only have an immune globulin to prevent anti-D. So there are no other immune globulins for other incompatibilities like KEL alloimmunization. And the consequences of this can be several fold. In utero, fetal anemia can occur. In the worst case scenario, fetal hydrops can occur when the fetal hemoglobin is about 1/3 of normal, and ultimately this can lead to fetal death without treatment. Afterwards, we end up with fetal jaundice. That's a breakdown of the hemoglobin that can occur in the baby with yellowing of the skin and eyes. In worst case scenario, we can result in bilirubin-induced neurotoxicity, which is a new term for the old kernicterus, where bilirubin actually can cross the blood-brain barrier, stain the basal ganglia, and lead to long-term neurologic problems such as cerebral palsy. Now, this is a recent study we published in Blood Advances looking at the prenatal blood screens in almost 10 million women between 2010 and 2021. And we concentrated on the 4 antibodies that cause significant fetal disease. There are over 50 antibodies that have been associated with HDFN, but most of them are associated with neonatal disease. But these 4, big D, big E, KEL, and little c, are associated with fetal disease. And we found them in 1.5% of all the antibody screens in this pregnant population. And if we look at the actual critical antibody titers in these particular cases, you'll notice that KEL outdid D. It was twice as common as D at a critical level in these antibody screens. To the right, you can see over time, the course of the study, how this incidence changed. Notice that D went up. We're not quite sure why that was the case, given the widespread use of RhoGAM. But the other antibodies remain very constant, again, indicating that this is a disease that is still with us and really isn't going anywhere and needs some new treatments if possible. So let's talk briefly about clinical care as it exists today. So today, the standard of care to detect fetal anemia once a critical maternal titer is present is to look at the fetal MCA, peak systolic velocity. And this is a vessel that can be easily seen on color flow Doppler. We can measure the peak speed of the blood in this vessel. And if it turns out to be 1.5 multiples of the median for the particular gestational age, that's indicative of moderate to severe anemia. And in those cases, what we typically do is move on to what's called chordocentesis, which you see illustrated here on the left, where we actually take a needle and either go through the placenta or through the amniotic fluid to the cord insertion and obtain a sample of blood to confirm the baby's anemia. At that point, we have blood available in the room to give compatible blood to the baby. We can do this as early as 15 weeks, although we really can't get to the cord at 15 weeks, it's too small, but we can put it in the peritoneal cavity. After about 20 to 22 weeks, we can usually get into the cord. And we can do these in a serial fashion with Rh negative, CMV negative irradiated blood up to about 35 weeks of gestation. The amount we give is based on the hematocrit that starts and where we want to target the hematocrit and the fetal weight. We have to repeat these every few weeks because we get bone marrow suppression doing these, and the baby's volume of distribution continues to increase as the baby grows. So the average number of IUTs is 4 throughout a pregnancy. We're pretty good at this after 20 weeks with a 3 to 5% perinatal loss. But as I mentioned earlier, if we try to do these under 20 weeks, the loss rate can be as high as 20%. Once the baby's born, we're not done. These babies have bone marrow suppression, have to be followed very carefully with weekly hemoglobins and reticulocyte counts. Excuse me. And some of these babies need a top-up transfusion at 3 to 4 weeks of age before they start making their own blood cells again. So let's switch gears and talk about early onset HDFN. So that would be, as I mentioned, a case where the patient has presented with a history of fetal disease at 20 to 22 weeks when the technical aspects of transfusion make the risk for loss much higher. This patient could present with a fetal death or fetal hydrops or just plain fetal anemia detected by MCA Doppler, as we talked about, requiring intrauterine transfusion. So this would be the definition of early onset hemolytic disease of the fetus and newborn. So what's exciting now is about a new monoclonal antibody that's been developed called nipocalimab. It's a humanized monoclonal antibody that is developed to target the FcRn receptor that Jim mentioned and to bind to it very tightly. As Jim showed you earlier, we recently published in August of this year our paper describing the results that I'll go over now of the phase 2 clinical trial that occurred using this drug in early onset HDFN. So the Unity trial was a phase 2 open label trial. All the patients were treated in patients who had terrible disease, a history of loss or transfusions before 24 weeks. Patients had to be alloimmunized with a critical titer to either RHD or KEL, and the fetus in the pregnancy of interest had to be antigen positive through free fetal DNA testing. There were 23 patients screened in this trial, in this phase 2 trial. There were 10 screen failures. The majority of these were because the fetus was determined to be antigen negative by free DNA analysis. So 13 patients were enrolled in 14 pregnancies. One patient terminated her pregnancy when she was noted to have evidence of genetic disease in her fetus, and she went on to be treated in a subsequent pregnancy. There were 12 live births. There was one fetus lost at the time of an intrauterine transfusion at 22 weeks in the trial. As far as adverse effects first in the mother, because we lowered their IgG levels to 15% of normal, we were concerned about the risk for infection. And there were infections in 8 of 13 of the patients. None required hospitalizations. Most of them were treated with oral antibiotics for things like urinary tract infection or mastitis. 2 patients ended up getting COVID. This was during the COVID epidemic. Neither were hospitalized. There were a total of 3 infusion reactions in 234 infusions, so a very low level of infusion reactions. They were all localized. Albumin levels, as Jim alluded to, did fall due to FcRn blockade, but these declines were asymptomatic, did not require treatment, and returned to normal when the drug was stopped. Likewise, there was a variable increase in total cholesterol, which again, as the drug was stopped, returned back to the normal level. Because babies get their IgG from their mother, when there is an FcRn blockade, it blocks all IgG crossing the placenta, not just the anti-D or the anti-KEL, but all IgG. So IgG levels were much lower in the babies at birth, and 5 of the 6 babies had low enough levels that they were supplemented with IVIG at the time of birth. When these levels were followed out for several months, they were noted to return to normal levels by 6 months of age. There were 12 infections in the babies. Most, again, of the infections were typical childhood type infections like thrush and cold. One baby did end up with COVID, but was not hospitalized. So these were felt to be minor, typical childhood infections. And now for the results. What you see here are the parameters in the first column. In the middle column of the patient's demographics for their previous qualifying pregnancy. And in the final column is the on-study patients who got the nipocalimab. First of all, the number of patients needing transfusions in previous pregnancies was 84% and only 46% in the on-study patients. The primary endpoint for this phase 2 trial was a live birth at more than 32 weeks gestation without the need for any transfusion. That never happened in a qualifying pregnancy, but it happened in more than half of the cases in the on-study patients. The gestational age at the first transfusion was markedly better, so that patients were transfused later, 7 weeks later than the previous pregnancy. There was no high drops detected in the on-study patients as compared to over half the patients in their previous pregnancy. The live birth rate changed from 38% to 92%, and the gestational age at delivery changed from 23 6/7 to 36 4/7 weeks. This is a graphic representation of the qualifying pregnancies. The X's represent the losses, and the triangles represent the transfusions. The green bars indicate the pregnancies treated with IVIG in their previous pregnancy, and the gold bars those who did not receive IVIG. To the right are in fact the on-study patients, and you'll notice the different colored bars. These are the escalating doses due to changing adaptation to pharmacokinetics in these pregnancies in this phase 2 trial, to the final colored bars, which were 45 mg per kg of adjusted fetal weight. Notice that the majority of the IUTs seem to occur at the earlier or lower doses. There was one IUT in patient number 11 that was late in gestation, and unfortunately there was one loss in patient 13 who had a complication of an IUT at 22 weeks gestation. These are some of the babies. Baby on the left is baby Daisy, who's the very first child who was treated as a fetus in utero. Mom had lost a previous child to Kell disease and had an uncomplicated pregnancy without IUTs. Baby on the right is from a Lithuanian patient who had lost 3 previous pregnancies. Although she required some IUTs later in gestation, she took home this beautiful young baby later on. This phase 2 trial led us to plan and begin to institute, which is currently in place, a phase 3 randomized trial called the Azalea trial for individuals at risk for severe HDFN. The criteria are a little bit broader. It's alloimmunization to D, big C, E, little c, or Kell. And the prerequisites are an antecedent pregnancy with 1 or more IUTs or a fetal or neonatal death. Again, the current pregnancy of interest has to have an antigen positive fetus on board by free fetal DNA. And the study will be a randomized trial 2-to-1 between nipocalimab and placebo. And of note, it is a blinded trial, so both the investigators and the patients do not know to what arm they have been randomized. So this is one of my favorite pictures to show from the movie The Last of the Mohegans in 1992, with these 2 gentlemen looking over the Appalachian Mountains. I do hope that this phase 3 trial proves fruitful and that we get approval for this drug, and that I will truly be one of the last of the Mohegans to put needles in babies and give them compatible red blood cells. Well, thanks for listening, and I'm gonna turn this back over to Jim. Yours, Jim.
Thank you very much, Ken. I think that we're doing a really good job of covering this in a relatively short amount of time, even though it's very complicated material. And therefore, I hope we will have lots of questions and discussion about various features of this. So I want to tell you for just a minute about fetal and neonatal alloimmune thrombocytopenia, which is the platelet equivalent of hemolytic disease of the fetus and newborn. There are well over 30 potential antigens that are involved, but by far the dominant one, at least in reported series, which have been primarily in Caucasians, as HPA-1AB or PLA1 or 2. You see the arrow indicating that that's on glycoprotein 3A, but there are many other antigens that could be involved as well. This is taken from a study we published in 1997 with about 100 fetuses whose previous sibling had had FNAIT, and now we were looking at what were the fetal platelet counts using fetal blood sampling, and this was primarily led by Dick Berkowitz. And you see that the majority of platelet counts, even by 25 weeks or so, were less than 20,000, whereas the normal fetal platelet count is essentially the same as the normal neonatal count. And in a different study published in Pediatric and Blood Advances in 2005, we looked and showed that you could get about 90% of cases of FNAIT if you used a cutoff on day 1 of life of 50,000, and you could get only about 50% if you used a cutoff of less than 20,000, but more than 3/4 of those would be FNAIT. This is the first study just to illustrate that in FNAIT you're able to use, and we've done a series of randomized studies with Dick Berkowitz and Jan McFarland, showing that you can raise the fetal platelet count when you give IVIG to the mother. And that's something, there's an algorithm for doses that was published about 10 years ago. And this is sort of laid the background because we believe that the majority of the IVIG effect here is actually by saturating FcRn and therefore crowding out the anti-HPA-1A that might otherwise get to the fetus. There is an ongoing screening study in the US and Western Europe. Mother is tested for HPA-1BB. If she's in the approximately 2 to 2.5% of women with that, she's tested for an HLA class 2 molecule called DRB3-0101. If she has that, that makes her one of the approximately 1 in 200 women who will have a high risk or a higher risk of making an anti-HPA-1A. At that point, the antibody level would be tested to see if it's pre-existing, and if there is no antibody, then the fetus will be tested, as Ken described, for HDFN to see if the fetus is HPA-1AB or 1BB, and thus likely to be unaffected. The point of this study, which is thus far accrued well over 10,000 pregnancies, is to establish a case for giving prophylaxis in the future. And the idea is that we would mimic what Ken described for HDFN. And this is some data from a publication from Peter Newman in Blood in, I think, 2022 or 2023, basically showing that if you have a mother who might be making antibody because you expose her to incompatible platelets, if you simultaneously give prophylaxis with either a polyclonal IgG or a monoclonal antibody, she will not make antibody and platelets will not fall. And the fact that this is so similar to HDFN is what gives us confidence that this would be an effective strategy. As Ken described, there's a study similar but a little bit different for the use of nipocalimab in pregnancies at risk for fetal and neonatal alloimmune thrombocytopenia. And HDFN got azalea, so FNAIT got freesia. And of course, I'm waiting for peony, but all right. In this study, it's a randomization 4-to-1 for nipocalimab as opposed to the investigator's choice of IVIG with or without steroids. And therefore, there is not a placebo arm. There is a version of this study ongoing in Norway and the Netherlands, and I am not sure of other sites also, of nipocalimab 2-to-1 to placebo, as described in the Azalea study that Ken mentioned. So with this, we come to the conclusion of the presentations. There's many issues to discuss here, but before we do that, we will want to assess the knowledge gained from today's presentation. So Lucy will share the poll questions again, and then we can look at the answers. So please respond to the poll questions. These are the same ones as before, identifying most cases of FNAIT in the baby. And we see here that 9 out of 10 people said to use a baby's platelet count, which would be obtained because of perhaps petechiae and ecchymoses. Next slide. Next poll question. Ken, why don't you do these?
Sure. So this question is all the following are serious complications of HDFN except, and it's hydrops fetalis, neonatal sepsis, severe fetal anemia, and kernicterus. If you'll take a vote on that for a second. That's right, everybody got that right. So kernicterus can still occur, believe it or not, if you're not watching the bilirubin levels very carefully in the babies after they're born. There are protocols by the American Academy of Pediatrics and curves for watching the bilirubin level after birth. So it really shouldn't happen anymore in modern medicine with these extensive protocols to follow the babies once they're born. And neonatal sepsis is not associated with HDFN. Next slide. So the next question is of the following, which all of the following are used as treatment for fetal HDFN except in utero transfusion, IVIG, steroids, anti-FcRn, and exchange transfusion. And everybody looks like they pretty much have that right. We aren't using, so steroids really don't have any place in the antenatal treatment of this. Anti-FcRn is experimental, as we talked about today, and is undergoing clinical trials. And so I think you all have gotten this right. And IVIG is used in some cases, but the standard of care is in utero transfusion, as we talked about.
Lucy, can you give us access to the questions? I'm not seeing them in mine.
Yes, you have access, but I can go ahead and read the question. Just to remind everybody, you can still submit questions in the questions pane of your control panel. Our first question is, excellent information, thank you. Question about the HDFN study. Would the goal be eventually to expand the indications to those pregnant moms who don't have a fetal loss in the past, but do have a child with incompatible blood group AG, hence putting current pregnancy at risk of alloimmunization?
Yes, so that's a great question. I'll take that one. So the question is, would the drug be available eventually after FDA approval for other pregnancies with incompatible fetuses on board. I didn't touch on this, but there's a growing body of evidence. This is well known in Europe and used for years, of the use of free fetal DNA to detect the at-risk fetus. We do that in the clinical trial. There are now commercial assays available by at least 2 companies in the US to detect the D positive fetus. So you would always start your evaluation, no matter what the maternal titer is, with a free DNA analysis. And the studies to date show very accurate capability to determine the fetal status. I think at that point, you would probably want to look at the titer at some point in the future. If this was a high enough titer to use a drug like this. Obviously, we are using a drug that can affect all IgG passage at this point in time to the neonate. And so we want to limit it to the patients who would have a fetus that's at significant risk. But long time, further down the pike, I do think there'll be a time when a drug like this could be used eventually in patients with very high titer and a positive fetus by antigen testing.
And Ken, you would include the MCA Doppler in that?
Yeah, that's a great question, Jim. So one of the concerns would be that if you wait till the MCA Doppler shows anemia, are we too late in blocking the placenta? So you want to think about, and we do this with IVIG right now, you want to think about starting it earlier to get that FcRn blockade so the antibody's not crossing. So I'd be a little concerned about waiting till the MCA Doppler was elevated and that the baby was already anemic. It may be sort of late to start the drug. So you'd probably want to start it earlier to prevent the antibody from crossing. We know IgG begins to cross between 10 and 12 weeks of gestation. And you begin to see early amounts, very low levels, but early amounts of IgG crossing from mother to baby. We have seen severe disease as early as 15 weeks in a fetus with HDFN. Unlike your platelet numbers, which I thought were impressive, we see that quite early. And so in very severe cases, very high titers, we can see fetal anemia as early as 15 weeks.
We just had a question. Apologies if I missed this, but were there serious, were the neonatal infections in the babies born to the moms on the anti-FcRn study, were these serious or non-serious neonatal infections?
So they were, none were serious enough to require hospitalization or IV antibiotics. The babies were all treated with oral medications and none required hospitalization. There were mostly thrush, ear infections, colds, respiratory infections, one COVID infection, but no baby required IV antibiotics or hospitalization. So we would still be concerned, and we are monitoring that very carefully in phase 3. But at this point in time, we haven't seen that. Jim, maybe you could speak to what infections have occurred in FcRn in myasthenia gravis patients, because those are older patients on other drugs. And what's the post-marketing data told us about that?
Well, let me, since we seem to have a little extra time, let me just cover one background part of that. As Ken told you, when you give anti-FcRn, depending on the dosage, the interval, et cetera, you drive down the IgG level very substantially. So I think, Ken, you didn't emphasize this, but in addition to blocking transfer of the antibody, you did mention that the mother's IgG levels got quite low. So you're reducing the maternal anti-red cell, or in my case, anti-platelet titer, in addition to preventing it from getting across. In the studies in myasthenia gravis, and there have been at least 4 studies in ITP, it's been surprising that despite lowered IgG levels, there have been essentially no serious infections that could be attributed to this. I think one thing that's interesting, going back to the fetus and the newborn, is in this study, and Ken, correct me if I'm wrong, there was concern that, hey, if you do a great job, just as you said, blocking the IgG from getting to the fetus, isn't the fetus the one who's really at the most risk of sepsis if they're born? And you pointed out that there were 6, I think, at least, who were born with IgG levels less than 200. Now, that's given that in this study, just to be fair, I believe the last infusion was at 35 weeks, and then between 36 and 37 weeks, the mothers received a dose of IVIG, primarily for their sake, but also for the fetus's sake, to try to increase the levels. So I think that while the mother's levels are low, because in general, the rest of their immune system is not really affected by this. I mean, their IgA and IgM are fine. They can make apparently new antibodies well, and that we don't think the T cells, for example, are disrupted, that infection in an adult is not such a big issue. But I think neonatal sepsis in a baby with a IgG level less than 200, especially if it doesn't come up after birth because it takes the fetus a while, may be a real risk. And I'm not sure whether the way it was done in this study was the best way, or maybe they should have just put in an umbilical catheter, given some IVIG to the baby, and then pull the catheter and be done with it. How have you thought about those concerns, Ken?
Yeah, I think we were concerned about that when we designed the phase 2. And so we talked with our pediatric immunologist about a number that's where the 200 mg per deciliter threshold came up, to say, well, that's low enough that we might have some concern about neonatal sepsis and infections. That's a number that really is hard to get your hands around. There are babies born to mothers who don't make IgG, and they seem to do fine, even though the mother's not passing any IgG over to the fetus because she doesn't make IgG. And looking at that information, those kiddos do pretty well. So we took the conservative approach in the phase 2 trial, not knowing how this would go. In phase 3, they don't get IgG. Either mom or baby don't get IVIG. We do stop the drug at 35 weeks, as you pointed out, and wait a few weeks to allow some beneficial antibody to cross. We're obviously letting the bad antibody cross too, so we don't want to wait too long. The FcRn blockade comes off at about a week. It begins to come off. And so we would suspect that some of the maternal IgG is going to begin to cross into the fetal circulation towards the end of the pregnancy. But your point's valid, and I think we have to watch this very carefully in these babies and see how they do. But there were no real blatant safety signals that preclude us from going on to a phase 3 trial. And of interest in the monkey studies, when they took the neonates and they challenged them with an antigen, a foreign antigen like a vaccine, they responded to that. And so part of the trial in the phase 3 trial will be to see how these children respond to their typical pediatric immunizations. And based on the animal data, we would suspect there would be no change in the way they respond to vaccines. But that will be assessed in the children in this particular trial. And so, as you point out, T cell function is not affected. The ability to make IgG with a new stimulus is not affected. And other antibodies like IgE, IgA are not affected either. So when moms breastfeed, their IgA will also get to the babies and without any problem.
Just to add a little more to that, given that I don't see any questions in the chat, and so I'm happy to get to learn more from Ken while we're talking together. There's an old study from Cates and Ballo, I think back in the 80s, looking at IgG levels in premature babies. And when they were born and had very low levels, like 200, 300, because of being very premature, they didn't actually make their new IgG any better than anybody else. And as happens physiologically, their levels fell even further. And my wife is a very well-known clinical immunologist, and she told me there are a very small number of cases where the mom's antibodies aren't normal, the babies aren't normal, and they have had serious infections. So I'm personally a little more concerned about this and think that, especially not doing anything to change the natural history, if you will, of what happens after FCRN, we'll have to see how it goes. It may be, and Ken, I think you implied this, that breastfeeding will be a particularly good thing in those babies to increase their ability to get immunoglobulin in, and of interest, they would get that, and they might get that, the IgG immunoglobulin from the mother, not the IgG, not the IgA, via FcRn receptors in the GI tract. So kind of a full circle thing.
Yeah, and again, to point that out along that circle, Jim, is that we know that, at least from our initial data and the animal work, that nipocalimab doesn't really cross the placenta in any great amount. And so they shouldn't be present inside or in the neonate to affect that capability of blocking FcRn inside the neonate. Again, levels are being measured, et cetera. But as you point out, FcRn receptors are present in the GI tract and allow you to absorb IgG even from the GI tract that's in breast milk. So that would be a good thing for these babies. And we are encouraging breastfeeding in all of these patients.
And Ken, just to go back to something, you mentioned the cholesterol going up, but I'm not sure that it was clear to everybody why, if you're getting an anti-FcRn, the cholesterol might rise. You'd be willing to explain that?
Yeah, to be honest, I don't think we're 100% sure. There's at least a hypothesis that if albumin falls, and we saw albumin go down, as Jim pointed out, albumin is also salvaged and recycled, circulating levels of albumin by FcRn. So if you block it, you expect a decrement in your circulating level of albumin. One of the theories about why cholesterol goes up is that you may be trying to maintain your oncotic pressure. And so there's an auto-regulation system. We know this is true in other patients with low protein levels, that their cholesterol levels go up. And at least one of the theories is that perhaps you're trying to maintain your oncotic pressure in your serum, and by doing that, you raise your cholesterol. Again, these were transient increases in cholesterol. They weren't off the map, and they came right back down afterwards. But for long-term use of FcRn, I can see where that might be something to be somewhat concerned about. I know that's being studied in some of the myasthenia gravis post-marketing data. We had mentioned, and I think you and I talked about this a little bit earlier, about the use of IVIG. It's probably worth touching on. There's
just one sec before you do that.
Sure.
I just want to say that we've talked entirely about nipocalimab.
Yep.
There are at least 4 or 5 different anti-FcRns in trial, and I only bring that up now because one of them that was doing a study in thyroid eye disease actually had their study stopped because the cholesterol went up so much. So I think it needs to be monitored in patients on this, just as you said, and long term, it doesn't appear to be a problem, but we're waiting to see. And I see pregnancy as an ideal use in the sense that, as opposed to, let's say, lifetime, you have a finite period. But please go back to the IVIG, since I think that's really interesting.
Well, I mean, I think that IVIG is probably the poor man's FcRn receptor blocker, right? You and I talked about that. It doesn't have the same affinity for FcRn as nipocalimab does, which is designed to target FcRn. And so we see more and more people using IVIG in the treatment of HDFN. Originally, the few papers out there, retrospective papers, talk about using it with early onset disease, but because it's not a complete FcRn blockade, what we see in the majority of pregnancies is a prolongation until the first IUT is necessary. So you can buy some time, if you would, as compared to the previous pregnancy, but you ultimately still do transfusions. But again, if you had early onset disease, as I pointed out, and you had maybe a transfusion at 18 weeks or 20 weeks, buying a few weeks to get a pregnancy to 24 weeks or so, when technically it's more feasible to do an IUT, would be important. So we see a growing group of people using IVIG in those EOS HDFN pregnancies to buy time. You still have to monitor those pregnancies pretty carefully with MCA Doppler. And on occasion, you go in much earlier than you thought based on the Doppler changes despite IVIG. So it's not a panacea. It's sort of a poor man's FcRn receptor blocker.
To talk about that for a minute, when somebody like you talks about an IUT, I mean, I don't mean this wrongly. You're so experienced and know so much about it that you make it sound routine. But I believe, and correct me if this is wrong, that in MFM circles, the use of any type of fetal blood sampling, let alone transfusion, has probably been decreasing, and that there are centers that are concerned that they won't have enough people with enough expertise to have the lowest possible complication rate when you do this procedure. Is that like overestimating the problem, or is that fair?
No, that's more than fair, Jim. I think that you hit the nail on the head about experience with a very delicate procedure. We learned how to do IUTs through doing amniocentesis for genetic problems. But with the advent of non-invasive prenatal testing, which many women would rather have, I always thought it was interesting. The marketing people came up with the idea of calling it non-invasive. They don't want to be invaded. They don't want to take the risk of an amniocentesis. So we're seeing even a decrement in learning curves for training fellows to do amniocentesis. And that's a much easier procedure to do than a chordocentesis, where you're targeting a very small target of the umbilical cord. So there's only one paper I can find published on the learning curve of transfusions. It comes out of the Leiden group looking at their experience. And it takes 30 to 40 procedures to learn how to do this. And they actually quote that you should be doing 10 per year as a center to maintain your competency. And I think those are good numbers. And we're seeing fewer and fewer centers who have that experienced team, whether it's blood banking, analysis of the hemoglobin on the spot in the OR, whatever. And so I think the development of a drug like this, it's going to allow us to treat the disease medically in the majority of cases, given the decrement in experienced, interventionists, is going to be an important development in this disease. I really do.
I don't mean to tap into your conclusion, Ken, but I think it's also important for our audience to appreciate that in, let's say, the 1950s, and Ken, correct me if I'm wrong, more than 1% of all deliveries in the US were affected by HDFN, and as many as a quarter of them died, and another quarter had clinically significant disease. So this has really been a remarkable thing. And the flip side that's a little sad is birth rates are going down everywhere except maybe Africa in particular. And 50% of the population in the world who should get prophylaxis with anti-D do not get it. And that is why there are still cases around, I believe, in the large part. So Ken, why don't you take us home?
Yeah, I'll conclude by saying it's been a pleasure working with you today, Jim, to put this presentation together. And I think that's all the time we really have for questions. But on behalf of the foundation, we'd like to invite you to the 5th convening of the Uterine Hemostasis Colloquium. That's going to be on March 13th in Coronado, California. We're excited to be sharing even more on this topic. I'll be one of the speakers there in person, and you can follow the link in the chat to learn more and register. But I want to thank everybody, and you should be getting an email about an evaluation with a link to get your educational certificate. But on behalf of myself and Jim Bussel and FWGBD, we appreciate the support by Janssen, and we look forward to being able to do this at no cost to the attendees. But thank you all for your attendance today. It's been fun. Thank you so much.
Thank you, Ken.